It's early. Okay, you're 18. Should we wait? Or should we begin? We will wait for a couple of minutes, maybe. Did you have your coffee? You don't see me anymore. I wonder why. Why is that? Do you see me? You don't see me. Why is that?
We can see you.
You can see me? I cannot see me. Okay, I have two monitors. In one, I see you. And me, of course. Okay. How are you today? How was the course of yesterday's course with Professor Bogdan Popescu?
Not too bad. It was okay.
Okay, you talked about what?
Heart failure.
Great, this is very nice. And what about heart failure? You talked about diagnosis, definition, signs and symptoms, maybe. What else?
Etiology.
Okay, great. And nothing for the treatment?
Today we have the course on the treatment.
Okay, that's great. So, should we begin? 24, it's great like this. Let's go. We are trying to go for another. Please let me in. Okay, so another case presentation. Do you see me? I don't see me.
Yes, we
can see you.
Okay, great. Okay, so 73 years old male patient who came to the hospital for dyspnea with orthopnea, marked fatigue, important bilateral pedal edema, and we begin with the anamnesis that you should do. Let's go. Go on from now.
Okay, so does he have any allergies or does he smoke?
He smoked for a long period of time. I'm not sure for how long, and he has no allergies.
What about his family history?
He has no family history important for cardiovascular diseases.
The reason he was admitted to the hospital?
Yes, he was admitted to the hospital 4 times this year for decompensated heart failure.
What kind of did he take any treatment till now?
Yeah, he has a treatment for heart failure. He's taking furosemide, spironolactone, diuretics. He's taking bisoprolol, high dose 10 milligram, ramipril, clopidogrel, aspirin, atorvastatin, and metformin. We will talk the treatment in a couple of minutes.
Did we already say how long he's been having these
drugs?
No, the issues that he came to the hospital for? Did we say how long it's been going on or anything like that?
He has the pathologies starting with 2009. He began with an anterior infarction, anterior STEMI, and then he had an aortocoronary triple bypass in the same year, 2009. He was diagnosed with heart failure in 2015, so 5 years ago.
Does he suffer from any other diseases or?
He has type 2 diabetes mellitus, and he's taking some metformin for this, and he's hypertensive. And he has a chronic kidney disease for, I don't know how long, a couple of years. I have a can with Dominican Republic. That would have been nice. Okay, go ahead. Something else? Okay, you have the symptoms. Marked fatigue, dyspnea, important bilateral pedal edema. You asked me about his personal pathologic history. That was very nice. Allergies, family history, great, but you did not ask me anything about the symptoms. Ask me about the symptoms, because it is important.
Like how long he's been having the symptoms,
Great.
or how serious they are, or what aggravates them, or makes
Great.
them, what alleviates.
So excellent, we can go ahead. He has the symptoms worsening during the last few weeks, although he increased his doses of diuretic from 40 milligrams to 80 daily in the last 3 days, and nothing happened and nothing improved his clinical state. He's having marked fatigability when he is doing, I don't know, daily activities. He cannot wash, he cannot do anything else because he is very tired. And the bilateral edema started to grow a few weeks ago. Great.
So this is NIHA 4?
NIHA 4, yes, that's great. Okay, so his personal pathological history, he had an anterior STEMI in 2009, and you heard about this. Conservatory treated because of the late presentation. Triple aortocoronary bypass with internal memory artery on the left descendant and circumflex, and he had a venous graft on the right coronary artery for trivessel disease. In 2014, a coronarography was made, and it showed the occlusion of the venous graft on the right coronary artery. He was diagnosed with heart failure with reduced ejection fraction. He has moderate mitral regurgitation, which is functional, type 2 diabetes from 2004, grade 3 arterial hypertension, and chronic kidney disease. It's in stage 3A with a glomerular filtration rate of 51 milliliters per minute. In the last year, he had 4 rehospitalizations for decompensated heart failure. Despite the maximal recommended treatment, target doses of beta blockers, ACE inhibitors, and MRAs, which are spironolactone and eplerenone, but you will find this today, and you will talk about this today, but we might get into the subject, and it will be more easier for you in the course. So what is an anterior STEMI conservatory treatment because of the late presentation? Can anyone tell me? You cannot be wrong, so go ahead and tell me anything you want.
Maybe just beta blockers?
Conservatory treatment is like we don't have angioplasty. We don't have any stent because the patient presented late to the hospital. What does late mean in STEMI? So
24 hours.
12 hours. 12 hours is the window, the therapeutic window in which we can go for immediate angioplasty. After 12 hours, we might do it after 12 hours until 24, but it's the exception in cases of cardiogenic shock. So 12 hours, just remember, the first 2 hours are very important, and it's the first indication to go for per primum angioplasty, but 12 hours is the therapeutic window. So interior STEMI conservatory treatment means he had all the treatment we know, antiplatelet, anticoagulation, beta blockers, AC inhibitors, and anything, statin in high dose, but not angioplasty. Okay, what does triple aortocoronary bypass mean? So you know that we must do this kind of intervention of bypass if we have several lesions and we cannot revasculate the myocardium through angioplasty. And this is the bypass coming from the subclavian vein. This is the internal mammary artery that bypasses this stenotic area in the LAD. And this arterial bypass is very nice because it does not have the risk of occlusion in the next few years. But for the right coronary bypass, you see here we have a venous graft who is placed in the aorta and bypasses this stenotic area. And usually this venous graft is the saphenous vein, and this one is not so good and not so durable in time. So it might have an occlusion at some point. You already know what heart failure with reduced ejection fraction mean. Signs and symptoms, and LV ejection fraction under 40%. This patient had, I don't remember, 30 maybe, 30, we will see. Okay, so this is not a discussion. Here we are with this patient. CKD, stage 3A, we said, not 3B, 3A. Do you know the stages of chronic kidney disease? So we have a normal or mildly decreased kidney function when we talk about stage 1, stage 2, stage 3A, until a glomerular filtration rate of 45-60. This is stage 3A. This is the point where we can have the progression of the chronic kidney disease, and this will progress until stage 3B, 4, and eventually stage 5 when the patient needs dialysis. And this is the point in glomerular filtration rate of 15-30, where we can no longer give medication if we don't adjust the doses and if we don't pay much attention. So it is important that the patient have chronic kidney disease, because it happens to have consequences, and the consequences are systemic, and we can no longer be very free with the medication. So we have to adjust the further treatment. And grade 3 hypertension, you know what it means because we talked yesterday, is over 180 systolic blood pressure or over 110 diastolic blood pressure. The current medical treatment for this patient daily was furosemide, 40 milligrams. He increased his doses till 80 milligrams per day, spironolactone, 25 milligrams, bisoprolol, ramipril, clopidogrel, and aspirin. After bypass, it's not very common to give dual antiplatelet therapy. Of course, the patient should have in his treatment aspirin lifelong, but the combination aspirin clopidogrel is taking into consideration in high-risk patients, in ischemic high-risk patients. It is not very common to associate these two if you don't have a stent in the first 12 months. Atorvastatin, 40 milligrams, metformin, and the patient had a good compliance to medical treatment. And you did not ask me this. It is important for the patient to have a good compliance. And what does it mean, a good compliance?
That he's taking all this medicine, he's not skipping doses or anything.
Okay, he's taking all his medicine. He is not depressed because of the disease. He doesn't eat salty foods. Okay. It is important because it is the main reason for heart failure, decompensated heart failure in Romania and worldwide. Okay. And another reason for the bad compliance could be the symptoms that can appear when you take so many drugs and when you experience some, I don't know, dizziness or dry cough, and the patient just stop their medication because they think that the medication is getting bad things for them. Okay, I don't see either of you. It's like I'm talking by myself. I don't like this. I can stop the camera too.
No, we have our cameras on.
You have your cameras on?
Yeah, I see Mikna. Yeah, he's
You
smiling. So, yeah, we're here.
Anyone? Just a moment. I want to see someone. Okay, Mikna. Okay, Nicholas. Thank you. Great. Okay. So, what was important? Patient is not correct. Okay, it was very late in the night when I modified this slide.
Okay, we understand.
I'm sorry for the mistakes that we have. Okay, it was important to ask me about the dyspnea at rest, exertion, if he experienced orthopnea, paroxysmal nocturnal dyspnea, it is important. Extreme fatigue, if the patient have sleep problems or symptoms when laying down, you have to ask the patient about the number of pillows they sleep on, because it can give a view of some more information. You have to ask the patient about the lack of appetite, the abdominal discomfort, because they could have systemic congestion with ascites. So this is very common into heart failure patients. About palpitations, about dry cough, if they have an AC inhibitor in the treatment. The weight fluctuations, in what period of time did they gain weight, leg edema, and for how long, sadness, depression, because these are comorbidities, depression, erectile dysfunction, which of course bothers them, and it's about quality of life, which is an important aspect in heart failure patients. You should ask about pulmonary diseases, chronic obstructive pulmonary disease, and sleep apnea. These ones, the last ones, are comorbidities that affect the patients and the quality of life, and if you treat them well, it doesn't matter because their life will not be the same anymore. So clinical evaluation and biological parameters just try to get some information from me. The patient is in front of you. Just start with vitals.
Okay, what is his blood
heart
pressure?
rate and
Go ahead. Okay, blood pressure 110/80.
his glycemia, because you said he was diabetic.
Let's do the first clinical evaluation and then biology, just to separate these two.
Okay.
Okay, clinical evaluation first, and then I will tell you about his glycemic levels.
Body temperature.
36.7.
His oxygen level.
89%.
Respiratory rate.
23 per minute. Is it high or is it low? When do you call it tachypnea? When it's
Over 20.
over 20, great. And in 80 years old patients, you can have the normal eupnea at I don't know 25. So you can have a higher cutoff of respiratory rate in older patients. Okay.
Heart rate as well.
Heart rate is 100 per minute regular rhythm. And when do you have a bradypnea? So over 20 is tachypnea.
Below 12, maybe.
Great. Below 12. Great. So you have blood pressure, heart rate, temperature, respiratory rate, saturation. Great. What do you need more?
Diuresis?
Yes, he has kept his diuresis, but it is less than 1 liter per day. Something else.
Heart sound.
Heart sound. He has a left ventricular gallop. He has a systolic murmur, grade 3, in the mitral area, and nothing else.
How are the jugular veins?
Intense and turgid jugular veins. We have important bilateral edema. He is dyspneic at minimum effort if he walks. And another important thing, you should auscultate the pulmonary area where he had a vesicular murmur, abolished, bilateral, basal, bilateral, and no crackles. Great.
What about his skin color or his chest?
He was normal colored. He had the post bypass incision on his sternum, and nothing particular. I guess you've finished the clinical evaluation, just a brief clinical evaluation, and we can go for the biology with the glycemic level of 139, 139, 38. milligrams per deciliter.
We can check. Is it just natriuretic peptide, or do we do like BNP? Is there a specific one that?
We can do anti-pro-BNP in the emergency department, and we do only the anti-pro-BNP. But in this patient, and I don't know why, we have a BNP of 1,650, which is high. Great. Anything else? Is it important he is an ischemic patient? His heart failure, decompensated heart failure could be precipitated by a coronary event. You did not ask me about angina. Nothing about angina. Just ask me about troponin. It has normal troponin levels. Okay. What else?
What about CKMB? So we can
Great.
have a different diagnosis.
Great. CKMB, a normal CKMB. He did not have angina, no. What else do you need? He is on diuretic treatment, so you will need
Creatinine.
Great. Creatinine, which was 1.8 milligrams per deciliter with a filtration rate of 51 milliliters per minute. So it's stage 3A. His urea was 78. It was normal. His sodium was normal and potassium 4.1. And hemoglobin level of 11.9. And
The glycosylated hemoglobin?
great, nice question. This one, this is 7.8. Is it high? Is it low? How is it?
It's high.
Great. It's very high, yes.
What was the cutoff value?
6.5.
Okay, thank you.
6.5 and maybe 7 in some of the guidelines, but under 7 for sure. Okay, we will talk about the cutoffs tomorrow, and we will talk about the patients I promised you yesterday, the categories of patients and the target and the targets for LDL cholesterol, for hemoglobin, for blood pressure, and so on. Okay, let's go further. You know this already, but I have more the 6 minutes walking test of 330 meters. We will talk about this. Okay, what is your first diagnosis based on the clinical examination and anamnesis? So you have a patient, and you must put the patient into one of the syndromes you know. You have the syndrome, the acute coronary syndromes. You might have the aortic dissection, the acute aortic diseases. You have the heart failure syndrome. You have one syndrome. So your first diagnosis that comes into your mind is your stage the diagnosis based on clinical examination and only anamnesis. So for this patient, it is very simple. It's what?
Decompensated heart failure.
Compensated heart failure, the first one. Okay.
Is the pulmonary problems, is it secondary to the heart failure?
Sorry, repeat the question.
The kidney disease, would it be secondary to the heart failure then? Is that why he has the edema maybe?
It might be, yes, because you know it is a strong relationship between the kidneys and the heart, and you might have a cardiorenal syndrome in this situation. I don't know what it was first, the kidney disease or the, let me just look once more, 2009 with heart failure, and the kidney disease was from I don't know what year. So it might be secondary to heart failure, yes. Okay, you know the functional classification. You should know the functional classification in your exam, because you might have some questions there. I think in the book they wrote in Romanian. I don't know if it is the support for you in Romanian or not, but it's wrong there. So if we compare the American stage, ACC-AJ, with the NIHA functional class, you have no correlation here. So this stage A, which in which you have structural heart disease, doesn't have an equivalent in the NIHA functional class. So here is class 1, NIHA symptomatic patient, class 2 in moderate exertion, class 3 minimal exertion, and class 4 symptomatic at rest. And you guess the patient had class 4 NIHA decompensated heart failure. What investigations do we need?
Echo.
Echo, great. Another thing. So echo here. I must take a look into my papers just not to go with the slides. Echo, but before echo.
X-ray.
X-ray, great. What else?
EKG.
EKG, EKG. Why do you need an X-ray? Why do you need an X-ray?
Differential diagnosis with
Right.
lung disease.
Disease is great, because the patient was hypoxic, because the patient had 89% saturation, and you heard something in your clinical examination, the abolished vesicular murmur, bilateral, and this patient is congestive. And if it is congestive, it might have some liquid there, okay? Okay, why do you need the ECG? Do you need
Would
it?
he have alveolar edema? Like on the X-ray, would it show?
Of course, it's the butterfly aspect. Yes, with the congested pulmonary, how do you call it? Oh. Hilum, bilateral, and the circulation into the apical areas. Yes, it will show. It's like you don't understand nothing. Of course, we can talk about this at in the unit of acute heart failure, because pulmonary edema is acute heart failure.
Okay.
Okay, so let's go ahead. What do you see here? You begin with the cardiothoracic index, yes? Did you do radiology?
No.
Not
You
yet.
did. Not yet. Okay. You shouldn't know very much here, but you have a cardiomegaly. So over 50% of this diameter of heart. So you have cardiomegaly for the first. You have congested hilum bilaterally. You have the
Pleural
cephalization.
effusion.
Sorry?
Pleural effusion.
Great. Why is that?
Because I can see, like on the X-ray, it seems I don't know how to explain it. It seems like cloudy, kind
Like
of like,
here, yes? You don't
yeah.
see the base like this. You have the upward concavity, so it is opaque in here. It might be opaque in here too. So you might have some liquid pleural effusion bilateral, and it is more on the right side. Yes, you're very right. Okay. The venous congestion, you see this venous cephalization into the apicals area, and this is all you can say about this X-ray. Okay, we will have the ECG, and I don't know if you're familiar with the steps. This is the illustration I use when students come to systematic to work, beginning with the rhythm, the heart rate, P wave, PR interval, QRX axis, deviation, forget about rotation, QRS amplitude, infarction signs, and QT duration and U waves if you have some. So we will do this ECG in this manner, because if you do it like this systematically, you cannot forget anything. You don't have to put a diagnosis, but you have to describe what you know and what you see. And if you do so in your extra points, even if you don't know the exact diagnosis. In your exam, in your final exam, you will probably have some, I don't know, STEMI, a not complicated STEMI, but be aware of the posterior STEMI, please, because we talked about this, yes. Okay, can you tell me what you see? First.
Heart rate around 100.
Okay. Great.
Regular rhythm.
Great. Anything else? Sinus rhythm or not?
Sinus rhythm?
Yes. P.
Yes.
Okay.
Is it normal axis?
Normal axis. Kind of.
Normal-ish?
Okay. Normalish. Okay. Okay.
Is it around zero?
Is it around 0? But you see this deflection positive one. It's higher than the negative one, so it is positive in AVF and positive in D1. It's okay. Around 0, you can say it. I would say it in the emergency department too. Anything else? That's a nice ECG. Not very.
PR, a short PR interval.
Might be. I'm not sure. It might be. Yes, it seems like it's a short PR interval. Okay, I agree. But it's not a problem. Let's skip this one.
Can it be a delta? I'm not sure, but
Okay, no. So, okay, forget about the PR, because I was expecting for this. It's not a delta. No, it's not a delta, and I might have modified the ECG for a better resolution, and it might be my fault here for the PR. So it is not a delta. It's not the problem the patient has.
Could it be a hypertrophy?
Great. Why is that?
The deep S waves and the V1, V2, and the high R waves.
Great. It's the
5 and 6.
Sokolov-Lyon, and you know the electrocardiographic criteria. Sokolov-Lyon, or you might have in AVL the R over 11. This is the kernel, and
yes.
you have it. You have over 11 millimeters, so it is a ventricular hypertrophy. It has the criteria. What else? The QRS complex is normal in duration.
Is it wide?
No. How many? No, it's not. You cannot see well the CCG, but it is not. It's so maybe 115. It's not.
ST depression
ST depression.
and elevation.
And elevation. And why is that? Let's do the differential diagnosis for the ST depression. For the ST elevation. V1, V2, and then depression. What kind of depression is here?
Downsloping.
Downsloping, and it could be secondary to the ventricular hypertrophy. It would be a repolarization abnormality due to ventricular hypertrophy. But you know this patient had the same ECG tracings from 2009, and you know that he had an anterior STEMI. Could this be an aneurysm with ST elevation? It's too big for the hypertrophic LV. It's too big, so it can be the ventricular aneurysm here, the anterior ventricular aneurysm. Okay, that might be all. Yes. Can it be a STEMI? Anterior STEMI? His arterial graft might have been occluded. Why is not a STEMI?
We have no support in the frontal leads. We have no elevation.
But we have the elevation in V1, V2, and it could be a septal STEMI. Why not?
It's normal axis.
No, you cannot do this only based on the ECG. You have to take into consideration the clinical aspects. He had no angina, first. He had the same ECG tracing as the other ECGs he had done in his life for 11 years, and it is not modified, and it is not modified, and he had a normal troponin level. So it cannot be a STEMI because of these remarks. You cannot do the exclusion based only on the ECG. Okay, what else? What else is is favorable for the ventricular aneurysm here? Maybe the lack of reciprocal changes, but you know the anterior wall has none. I don't see anything else on this ECG, so I guess we can go further. Oh, the films are not working. This is not good. I wanted to show to you some films, but it seems like we cannot do this. Okay, his Romanian ventricle string is 67 and with 54 millimeters. Is it dilated or not? So the dimensions are over 60. It is dilated or not? It is, yes? Do you hear me?
Yes.
Yes.
Okay, so over 60, we are talking about dilated LV. We have a dilated left atrium, you see here. It's almost like the left ventricle. And on the right, nothing really happens as we see this image in 2D. We have a dyskinesia of the anteroapical wall with an ejection fraction of 25%. I forgot to translate this slide. We have the mitral regurgitation, which was grade 3, moderate severe, which was functional and ischemic. What does a functional mitral regurgitation means?
Because of the dilation, so the trabeculae, they take the valve and the anterior one gets over.
Okay, so because of the restricted leaflet closure, because of the remodeling, because the patient had triple vessel disease, and because the LV is enlarged and the annulus is stretched, and here comes the mitral regurgitation. He also had some moderate right ventricular dysfunction, and that's why he got so congested, systemically congested. Okay, so we have the final diagnosis here, and we must argument the diagnosis based on what we know on his X-ray, on his ECG, on the biology, on the echo we have, and if we need something else we can do in order to support the final diagnosis. We have to take into consideration differential diagnoses like pulmonary diseases, like tamponade, but we have seen in echo there's no tamponade, like pulmonary thromboembolism that goes with the right ventricular systolic dysfunction, and with symptoms like intense dyspnea, but with I don't know, rapid onset. And the diagnostic workup, as we will see in short time. So we begin with the definition of heart failure. You already know, I've showed you 3 times the definition. These symptoms and signs, which are mandatory, sometimes can be absent in the early stages in HFpEF, but only here in HFpEF, not in HFrEF, never in HFrEF, or in patients receiving diuretics, which are very stable at the time you see the patient. But if the patient had signs and symptoms once in his life, you can make this diagnosis of heart failure. We will not go into deep because you already talked about. You talked about symptoms and signs which are typical for heart rate. Should we get through these ones, or you already know them? Do you feel like we should discuss this one? Why? The first question, why we have this ankle swelling in typical symptoms, and we have the, just a second to, I forgot where. In science, I have to have it in science. I don't know where. Okay, I don't know why. Here, peripheral edema, ankle, sacral, scrotal. So we have the symptoms here, ankle swelling, and the less specific sign, which is the peripheral edema here. Why is that? Is it the same thing? Do you know why? Is it a symptom or is it a sign? Peripheral edema. Just say yes or no.
No.
No, we know or we don't. Okay, so if a patient comes to you and he tells you, my ankles are swelling, I have edema, bilateral edema, starting for, I don't know, starting from 10 days, this is a symptom. So he's telling you you cannot see the edema. If you do the clinical evaluation and you recognize the edema and you palpate these edemas, then it is a sign, okay? So that's why you have the symptom and the sign, and it is the same thing. Okay, we had these immediate therapeutical options and actions. The furosemide was increased to a double dose in continuous IV, and the spironolactone was increased to 50 milligrams daily. We've done the pleural evacuation of 1,000 milliliters from the right, and the patient increased his exercise capacity based on his 6 minutes walking test. The congestion remitted. He lost 5 kilograms during the first days, and his BMP lowered at half, from 1,600 to 823 picograms per milliliter. So he had a favorable outcome. Okay, what is the 6-minute walking test? I have a film in the end of this class, but maybe you will get the film from YouTube and you will watch by yourself. It's a simple, easy to do test. You just ask the patient to walk for 6 minutes on a corridor and you monitor the patient before and after the test. It quantifies the functional capacity. It is a very good test in pulmonary diseases and in patients with heart failure, in patients after lung and heart transplantation, helps in stratifying the risk of patients, and it is useful in monitoring the treatment. But because if a patient have a low 6 minutes walking test when he is hospitalized in the first day, and then he is improving his exercise capacity and his length, it is for good reasons. You just have to have a stethoscope, you have to measure the blood pressure, you have to measure the saturation, you have to do an ECG before and after the test, but it's not necessary if you don't have cardiac coronary artery disease. And the dyspnea the patients experience during the test should be rated on this Borg scale. Nothing at all from 0 to 10, very, very severe. And this is the way we do monitor the treatment of patients in clinical practice.
What about 6, 8, and 9?
6, 7, 8, and 9. What's in here?
So they're all very severe.
Yes, it's severe, but you may rate it. You may ask the patient on a scale from 0 to 10, how severe is your dyspnea? And he will tell you 7. So you write 7 on the Borg scale, okay?
Okay.
Because the question on a scale from, this is the question we use when we refer to the severity of angina, when we refer to the severity of dyspnea. So it is not a very objective scale. It's very subjective, yes.
Okay, thank you.
What is the purpose of the treatment in this kind of patients? To identify and treat the cause of decompensated heart failure. Do we know the cause of this decompensated heart failure for this patient? Not yet. We did not discover anything, okay? We don't know. He is taking his drugs, he is compliant. He does have a glycated hemoglobin level, which is not very good and could be the reason for his decompensated heart failure, but not alone. And he had maximum treatment. We kind of don't know. Another purpose is to identify the comorbidities which have a great impact on the evolution of the heart failure: iron deficiency, diabetes, sleep apnea. To get the efficient decongestion until the dry weight of the patient, to optimize the treatment doses, the target heart rate, blood pressure, glycated hemoglobin and LDL cholesterol, and to try to lower the mortality rate and improve the prognosis on the long term. And why are these comorbidities very, very important in patients with heart failure? Did you speak about this in your course yesterday?
We had this slide, but I don't remember.
Okay, great, because it is great you had this slide, because you will see why these comorbidities are very important. You don't have to know the details I present you in this particular case, because it's a case for heart failure specialists maybe, and not for you, but to have a general look over what we are doing here and how to manage a patient and how to think of a patient in long term to try to give him years of life. It is important. So the importance of comorbidities in these patients: the comorbidities can interfere with the diagnosis process. It's not the case here. They can aggravate heart failure symptoms and further impair quality of life. They contribute to the hospitalization and mortality, you know that already, may affect, and this is important, the use of treatments for heart failure. If you talk about renal dysfunction and the use of ACE inhibitors that can get the low perfusion into the kidneys, or beta blockers if you talk about patients with asthma and with chronic pulmonary disease. But for this one, you have selective beta blockers. What else? Some drugs used to treat comorbidities may cause worsening heart failure, and we did not ask the patient if he took any NSAIDs or any kind of some other medication for some other, I don't know, pains or pathologies. And the interaction between drugs used to treat heart failure and those used to treat comorbidities are resulting in lower efficacy, poorer safety, and side effects. This is important to know about patients with heart failure. So why was this decompensated heart failure? As we know, the patient was on maximal doses, good compliance, medical monitoring every month, so he did not have reasons for decompensation at this point. The diagnosis test in patients with heart failure, we already know these tests, but we did not go through liver function tests, for example, bilirubin, AST, LAT, and GGT. We know the hemoglobin and the leukocytes. He was not infected. We know all this, and there were normal. You have the glycated hemoglobin, lipid profile. We do not know the thyroid, and this is not good. And why would you think we have ferritin and saturation of transferrin here? What is the reason for that? Do we have to know this? In heart failure patient, we do, because iron deficiency is a great comorbidity who can decompensate heart failure in these patients. And you have, if you don't look, you can miss the diagnosis and you don't get the proper treatment for the patient, and their heart failure will not improve. Okay, natriuretic peptides and additional testing if you need some in heart failure patients. So we just skipped some diagnosis tests. And if we go ahead and take line by line every test, you will see that his hemoglobin level, I told you so in the start, was 11.9, and with normochrome, normal, I don't know how to call it, and his low levels of ferritin, 62 and 70%. You don't have to know this, but I will let you know when you should remark something. The patient was diagnosed with iron deficiency. He has a mild anemia, but he could have iron deficiency even in the absence of anemia. And iron, you know, it's critical for the metabolism of skeletal muscles, of cardiomyocytes, and it goes with and iron deficiency results in mitochondrial dysfunction, in dysfunction of the enzymes, in apoptosis regarding the cardiac muscle, in tissue remodeling, impaired organ efficacy, and impaired exercise capacity with increased morbid mortality. So it is important to know these aspects too. We have two kinds of iron. It's stored iron in hepatocytes, sideroblasts, and reticular endothelial cells. And the parameter for knowing the stored iron is ferritin. As you know, it's an acute phase reactant, and we have a parameter which is the saturation in transferrin, parameter for the utilized iron, the circulant and intracellular iron, which goes into the metabolism of hematopoietic and non-hematopoietic cells. You should go back to the iron metabolism for more information. But the ferritin is an acute phase reactant. Don't forget this, and it can be high in patients with infections, and it can get you some problems if the patient with heart failure is associating, I don't know, maybe a urinary infection. Okay, so iron deficiency, not deficit, deficiency with or without anemia. Anemia can occur, is the common comorbidity in heart failure patients. It's frequently neglected. It's associated with reduced functional capacity, with increased mortality, can be actively searched, and it is very simple, but just by doing the hemoglobin level, the ferritin, and the transferrin saturation, can exist despite a normal hemoglobin level and must be corrected. Oh, this is Romanian English too. I'm sorry for that. It was very, very late. So we have these cutoffs. If we have the ferritin less than 100, we have an absolute deficiency of iron. But if we have the ferritin between 100 and 200 and the saturation less than 20%, we have a functional iron deficiency, and this must be corrected. Of course, we have to search for other causes of bleeding in case of low hemoglobin levels, but we will not go into details. And first thing we have to do is to administer ferric carboxymaltose. And why not doing something, I don't know, more easy, just to supplement the iron with all the iron drugs you know. Why we have to give it IV, this ferric carboxymaltose, which is a complex with iron. Do you know this? No, because the absorption is not very good in all this preparation that we have, the common ones. And you know that the gastrointestinal tract is somehow inflamed in heart failure patients, so the absorption will be lesser. From another point of view, these are medications that are not well tolerated, and the iron deposit will take some, I don't know, from 2 to 6 months to be completed without this ferric carboxymaltose, which is the best treatment we have so far for patients with heart failure. This is why we don't choose another treatment, but we will choose this new one. The follow-up should be in 1 month with re-administration of another dose, but I don't want to get very deep with you because it's not, especially for you, this one. The main and the important issue here is to know about comorbidities that can precipitate decompensated heart failure in heart failure patients. Follow up 1 month and 6 months after, because we have to treat this disease. And then 1 month in 1 month follow-up, of course, we should search again for the ferritin, the saturation, and the hemoglobin to see the spectacular results after administering utilizing the ferric carboxymaltose. And we have an elevated levels of ferritin, 27% saturation in transferrin, and 13.2 hemoglobin levels from 11.9. So this is good. Okay. In follow-up 1 month, we see the patient is clinically stable. His blood pressure is 105/70, heart rate 85, no pulmonary congestion, no systemic congestion, dyspnea at exertion. He is in class 2 NIHA, and he has this daily treatment, as we know, with creatinine 1.7. This time we have the anti-proBNP, which is 1000, and it's not very good to compare, because you cannot compare the BNP with the anti-proBNP. But we think it's under 800 as the BNP was at discharge. So if you compare the natriuretic peptide, it is better to compare the anti-proBNP for the whole period of time, or the BMP, but not one with another, because it's like you're comparing apples with pears, so it's not very good. Okay, what should we do now? Do we have something to do? You did not go into the treatment. You will go into the treatment with Dr. Kionchel, and you will see this treatment algorithm with start. Just a few words. I don't want to get into deep. We start with ACE inhibitors and beta blockers. He will tell you why. You will go for MRAs, and then if the patient is still symptomatic and has the ejection fraction less than 35%, you have some choices. Even you change the medication to sacubitril, valsartan, arni, you complete the treatment with devices, or if the sinus rhythm is over 70, you can get some ivabradine to lower the heart rate for the patients and to stabilize the heart failure if the patients are still symptomatic. Yes, these ones are not important for you in this moment. So we have a patient with heart failure, reduced ejection fraction, LV ejection fraction 30%, frequent need for hospitalization for decompensated heart failure, a systolic blood pressure under 110, in sinus rhythm, in tachycardia, because he had 83, 90 beats per minute. He has no indication for CRT. His QRS complex is 130 maybe milliseconds, so he has no indication for resynchronization. He has over 3 non-cardiac comorbidities. He has maximum tolerated doses of guideline optimized medical treatment, and he is stable after decongestion. So what do we do next? So the first to come, it's let's do nothing. We shouldn't do anything. The patient is stable, maximum medical treatment, and the perfect is the enemy of good. Or we should do nothing because we have no recommendation in this stage of the disease. And I will show you again the recommendations. What do you think we should do next? The patient is stable. You have seen he is not congested. He has no edema. He has no pulmonary congestion. What should we do next?
Evaluate need for CRT or ivabradine.
Great. Who told me this?
Mihna.
Mita. Great. Yes, evaluate the need for CRT. So the need for CRT means the class 1 indication is QRS complex over 150 milliseconds. Of course, you can do it 130, 149 when you have the aspect of left bundle branch block, but you do not have a left bundle branch block and you do not have the QRS complex more than 150. So you stop here. The patient does not need an CRT in this in this moment. Maybe he will, of course.
I have a question.
Yes.
Wasn't our patient QRS duration 140 or
30.
35?
It's 130. I've written, and if you want to see the ECG again, we can. But it's around 120. We said when we looked over. Do you want to see the ECG again?
No, it's okay.
No, but it wasn't a left bundle branch block for sure, and the duration, it's not over 130. This is why we did not go for the CRT in this moment. Okay. What else? You said ivabradine. Of course, Arnie, but we did not have at that time Arnie. Now we do. You will talk about this today with Professor Kionchal. Ivabradine is the right answer for now. Okay. I said here the patient is treated well and he is in the plateau phase. And I showed you some pictures. We will discuss ivabradine in a couple of seconds. Okay, where is this patient in this chart? So you see the patient, this is the point when the patient is getting discharged, and this is the risk of the patient. And you see the risk is rising until 2 months after discharge. So this area here, black, and this one here, are areas in where the patient has greater risk. The patient has the risk of immediate hospitalization or risk of death because of improper decongestion. And even if he is not symptomatic, even he hasn't signs and symptoms of heart failure, he could have subclinical congestion that will worsen his prognosis. So the patient is not here in the plateau phase from 4 months up to 1 year and a half. He's right here. So if we can optimize the treatment, we should do it. And this is an important illustration that shows that every hospitalization for acute decompensation will worsen the prognosis in long term and will decline survival rate. And you should remember, if I told you in the beginning, that the patient had 4 hospitalizations this year for decompensated heart failure, this is not good. This is a patient who is lowering his survival rate by these episodes of decompensated heart failure. Okay, we should do something or not, and if we are not sure, we can use risk calculators. You don't have to know this, you just have to know they exist. And risk calculator are taking into consideration some parameters which refers to the NIHA class, to comorbidities, diabetes, pulmonary disease, the severity and the lasting of heart failure, and the treatment creatinine ejection fraction. And by calculating this one, we see that the risk of dying of the patient in 1 year is 24%, and in 3 years it is 52%. So the risk is very high, and we decide to do something for this patient. So we use this one here. It's from the latest guideline, and we have an indication for ivabradine that should be considered to reduce the risk of hospitalization in symptomatic patients like ours with less than 35% ejection fraction in sinus rhythm, and if they have a resting heart rate over 70 beats per minute despite the correct treatment we administered. And we see the up to titration from 5 milligrams to 7.5 twice daily. It is not important for ivabradine, which is a if channel blocker, and you will tell me about ivabradine on Friday. And in 6 months, the patient had a better blood pressure under medication, heart rate of 60, the 6 minutes walking test, 410 meters, it is already better than before. The LV ejection fraction was the same, 30%. He had no side effects and no decompensated heart failure in 6 months, which was great. So, why? Okay, do we stop? We do not stop. The patient might be in need for implantable cardiodefibrillator in secondary or in primary prevention. Tell me, in secondary or in primary prevention?
It's
Do you
written
know?
primary.
Primary prevention. Okay, if we see that the patient is not very stable and it is symptomatic in 3 months, we will go for the ICD in primary prevention. Primary means before an event happens, and secondary means after the event happened. After the event, what kind of event? Sudden cardiac death, ventricular tachycardia, and that's it. Okay, so secondary prevention, we go for a defibrillator after sudden cardiac death or ventricular tachycardia, and primary before that. CRT, as we talked about, when indicated, when QRS complex gets more than 130 milliseconds, or the patient gets the left bundle branch block, but it is not necessary. So he can have the QRS aspect of non-left bundle branch block. The follow-up of the iron deficiency, we already diagnosed, and just be aware of the correctable targets for diabetes. He has a high glycemia levels, high glycemic glycated hemoglobin, and we should lower this with proper medication and proper medication for heart failure. You will know about this one in your course today. Hypertension cutoffs, don't keep the tension above 140, the systolic one, and of course heart rate. So take-home message is the iron deficiency, a common non-cardiac comorbidity, and all the other comorbidities are important. Iron deficiency can exist without anemia and is associated with worsening symptoms with reduced functional capacity. It can be identified very simple, and treating it is associated with improvement of symptomatology, quality of life, functional capacity, lower hospitalizations, and of course, therefore improved prognosis in long term. Heart failure needs a comprehensive approach. Every bit matters, is a correctable target. The heart rate in heart failure, every bit, every evaluation, every hospitalization matters through the opportunity of correctly optimizing the treatment. And although congestion represents the main factor responsible for decompensated heart failure, other targets that lead to congestion should be identified and treated. There are a lot of mistakes here on this slide. I will modify them all someday, and I'm sorry for that. Thank you for today. Do you have any questions?